Good evening, everyone. Welcome to the 177th webinar. And today we don't have Astani sir as he's traveling. He's coming back from Singapore. We have Alka ma'am today. Ma'am is going to take up this webinar 177 on vitamin B12 and vitamin D in health and diseases. Thank you, ma'am. Thank you, ma'am, for taking up this webinar.
Okay.
You can start.
Good afternoon, everybody. And you must be wondering that what is this topic? Vitamin B12 and vitamin D. These are two common vitamins you are using daily in and out. And what am I going to talk about it? There are certain things that we have to be very clear about the use and the functions of these two vitamins. Yeah. Preeti, just change my slide. Hello, Preeti.
Yes, ma'am.
Just this slide is not changing.
Ma'am, you can click on the yes.
Now
yes,
it is changed. Okay.
Yes.
Okay, so we are talking about vitamin B12. Vitamin B12 is also chemically known as cyanocobalamin. As the name suggests, it has a cobalt atom inside. Now, cobalt is present in many molecules in the body, both in animals and in the plant kingdom. Let us concentrate on this cyanocobalamin. Cyanocobalamin is a water-soluble vitamin. What is the daily requirement for an adult? It is 1 to 2.5 micrograms. 1 to 2.5 micrograms. Whole day we are eating chabbar. Is it difficult to get 1 microgram of vitamin B12 per day? This small quantity must be available from food. However, please remember, it is solely synthesized by microorganisms. So it is not present in the plant kingdom. Therefore, it is available only from the food of animal origin. So if you are eating meat, fish, or dairy products. How many of us are really meat eaters or fish eaters like Americans and Europeans? Day in and day out, right from breakfast, lunch, dinner, they go on eating the meat. However, and we Indians, we eat meat, if we are really non-veg eaters, once a week, fish once a week, or maybe alternate day. Vegetables, fruits, and food of non-animal origin are free from cobalamin. And therefore, a recent survey has shown that more than 50% of adult Hindus have subnormal cobalamin. This is from Harrison, I'm telling you. Harrison has mentioned it specifically, 50% of adult Hindus. It is nothing to do with the religion, but it is something you can take it as Indians, because most of the Indians are vegans. And as I said, if we are eating some non-veg food, it is once in a while. Therefore, our dietary source of 1 microgram of cyanocobalamin is very, very scarce. Therefore, even in US and Europe, most of the food products are fortified with B12. The same thing is happening here, that nowadays we are taking this cornflakes and oats and like an American breakfast. These are fortified with vitamin B12. Now, how is this B12 absorbed? Suppose if it is in the food, how it is absorbed? Now, it is present in the non-vegetarian diet. So, in the non-vegetarian food, this will be paired with a protein. So, it is a protein complex. Now, this protein complex is released in the stomach by the enzymes. Then in the jejunum, and then it goes to the ileum, because the absorption site of the ileum, I mean, the absorption site of the B12 is ileum. Remember that. So we take orally the food, and that food, that B12, whatever is present in our non-veg diet, has to pass through the whole of GI tract and reach ileum to get absorbed. I am dwelling upon this a little more in detail so that you will understand the etiology, why we are deficient in B12. Now, when we take a food product, when there is a protein complex of cobalamin in the animal product that we have taken, it is acted upon by saliva, the gastric juices, the pepsin, and this complex is broken. That is how the B12 is released. Now, this B12, which is released in the stomach, has to reach the ileum, and therefore we have what is called as carrier proteins. Okay, so release cobalamin binds to the carrier proteins are called as haptocorins. They carry the B12 from the stomach to the ileum, the small intestine. What is important, the essential for its absorption is intrinsic factor. The haptocorins are just like vehicle, or these are towing vehicles. They are carrying the B12 from the stomach to the ileum. But for the absorption of the B12 in the ileum, what is most important is the intrinsic factor. This intrinsic factor is released or secreted by parietal cells in the stomach. These parietal cells also secrete hydrochloric acid in the stomach. So hydrochloric acid converts pepsinogen into pepsin, which breaks this proteolytic protein complex which is present in the food, and the B12 is released. Now this B12 attached to the haptocorins is carried down to the duodenum. In the duodenum, there are other digestive juices, particularly from the pancreas, which come. And these pancreatic juices further break down or separate this B12 from the haptocorins or their protein complexes. Now, this B12 in the duodenum gets attached to the intrinsic factor. Now, this intrinsic factor is released by the parietal cells, which are present in the fundus and the body of the stomach. So from the stomach, intrinsic factor also goes to duodenum. The B12 complex with haptocorins go to the duodenum, where the pancreatic digestive juices is separated and it gets attached to the intrinsic factor. So intrinsic factor will now carry the B12 to the ileum. So this is the long route that the B12 takes to get absorbed. So cobalamin from the food, there are three transport proteins. One is haptocorins, I told you. Intrinsic factor is second one, which is most important because that is the factor which will help the absorption of B12 in the ileum by endocytosis. So if the intrinsic factor is absent, B12 cannot be absorbed. And then in small amount, transcobalamin is another transport protein which carries little amount of B12 from the stomach right to the ileum. So what are the causes of low B12? I'm not talking about total deficiency of B12. I'll talk about it little later. But what are the causes of low B12? Because as I said, 50% of Indians have low B12. One is deficient diet, vegans, vegetarians. Then most important, deficiency of intrinsic factor. Deficiency of intrinsic factor, that means it has to be a disease in the stomach. And as I told you, the secretion of intrinsic factor goes parallel with hydrochloric acid. So if there is atrophic gastritis, hydrochloric acid is not secreted. Intrinsic factor is not secreted. If I remove the stomach, partial or total gastrectomy, maybe for carcinoma of the stomach, or if there is infiltrating malignancy in the stomach, intrinsic factor will be absent and therefore there will be low B12. Atrophic gastritis, partial or total gastrectomy. Now, up till now, we were doing partial and total gastrectomies for malignancy. Nowadays, we are doing to treat obesity, and that is bariatric surgery. So, all patients of bariatric surgery have to be supported by B12 because they will be deficient. Then there is something like autoantibodies against parietal cells. In fact, when pernicious anemia was first described, they found some antibodies which are destroying the parietal cells. Today we know these are autoimmune diseases, and that autoimmunity, there is autoantibodies against the parietal cells. So parietal cells are destroyed, therefore hydrochloric acid is low and intrinsic factor is absent. So if intrinsic factor is absent, naturally the B12 cannot be absorbed because intrinsic factor is not only carrying protein, it carries the B12 and helps it to get absorbed through the ileal mucosa. Hypothyroidism, which nowadays I'm seeing it very commonly. I don't know why it is rising. Maybe somehow we have increasing incidence of autoimmune diseases. So hypothyroidism is an autoimmune disorder. As you get antibodies in hypothyroidism, 30% of the hypothyroids have parietal cell antibodies, and therefore they have low B12. For hypothyroidism, I do TPO antibody. But if the TPO antibodies are high, that is the cause of hypothyroidism, autoimmune thyroid disease. In such cases, parietal cell antibodies are also high, and therefore these are the people deficient in B12. So we have come from the diet, the stomach, the diseases of the stomach, autoimmunity, and lastly we come to ileum, where it is going to get absorbed. And in ileum, we have certain diseases, malabsorption syndrome or Crohn's disease. Once in a while, you might have come across with a ileocecal lump. And up till now, we used to think that ileocecal lump means it is tuberculosis. But now we know the other differential diagnosis is a Crohn's disease. It's an inflammatory disease of the ileocecal junction. So I told you about that. I told you about causes in the stomach. I told you about causes in the ileum. But the most important is absence of intrinsic factor. Now, intrinsic factor will also be affected by certain drugs. Proton pump inhibitors. We use proton pump inhibitors to decrease the secretion of hydrochloric acid. Naturally, it will affect also the secretion of intrinsic factor and will lead to low B12. Prolonged use of metformins, anti-epileptics, dilantines, and methotrexate. And you being family physicians, you must have seen a large number of rheumatoid arthritis, which is again increasing. And all these rheumatoid arthritis, they are treated with methotrexate. Along with methotrexate, naturally, because to combat its side effect, we give folic acid, folate. But folate also acts like B12. However, methotrexate also causes B12 deficiency. And last and the most important in our country or in any country is alcohol, chronic alcoholism. Alcohol, the patient goes on drinking, may cause alcoholic gastritis. This patient will not take food properly, which will lead again to dietary deficiency. And alcohol per se causes a deficiency of vitamin B1, B6, and B12. Why B12 is important? Cobalamin has a cobalt atom. It is present in many different chemical forms. It is present in mitochondria. The most important function of B12 that it acts as a cofactor in many enzymatic functions inside the cells, all the cells, neurological cells, cardiovascular cells, and all the cells, because it helps in synthesis and repair of DNA. And you know, DNA is an integral part. Of course, it is the molecule for a cell. And therefore, B12 plays a very pivotal role. So it is a cofactor for many enzymatic functions. And therefore, when there is low B12, the manifestations are very subtle. And therefore, we have to remember the causes, we have to remember the conditions, and try and support them with replacement. The B12 is stored in the liver. And you know what is the storage capacity? The liver stores contain 1 to 2 milligrams of B12. So even if I say 1 milligram, that is 1000 micrograms. My daily requirement is 1 microgram. That means per year I will require 360 micrograms. See, if I'm totally deficient in B12, it will take 2.5 to 3 years for the manifestations of deficiency diseases. Do you get my point? So if my diet is deficient, I'll get B12 from my stores. But if we are not replenishing the stores, one day or the other, the liver stores will get deplenished, and then the deficiency diseases will occur. There are two deficiency diseases of B12, all of you know, megaloblastic anemia. This is also called as pernicious anemia. And now we know that the basis for megaloblastic anemia is autoimmune. It has antibodies against the parietal cells. And the other, the B12 affects the nervous system and causes subacute combined degeneration. These two will occur when there is a total deficiency of B12. That means when we have finished our liver stores also. But before that, if the B12s are low, which are often seen in our people, sorry, what will be the manifestations? So the manifestations, as I said, very subtle. Fatigue, increased fatigability. There is shortness of breath. दम लगता है, मालूम नहीं क्यों. There is anorexia, lot of water brush, don't feel like eating. Like all other B complex vitamins, there will be glossitis. Can't tolerate even little chilies. Now this glossitis is common with iron and all the B complex vitamins. Glossitis, angular cheetosis. Homocystinuria. Now this homocysteine goes on increasing if there is a B12 deficiency. And this high homocysteine levels will have cardiovascular manifestations. The B12 is necessary for neural functions. and therefore people will have neurological and psychiatric manifestation. They may complain of tingling and numbness. Okay. Now, if it is a classical peripheral neuropathy, there will be tingling, numbness, which is bilaterally symmetrical, which involves globe and stalking area. But we see large number of patients, they have a very vague tingling and numbness. It doesn't fit in the picture of peripheral neuropathy. People complain of unsteadiness. I can't maintain my balance. Particularly when they close their eyes, they can't stand steady and they try to sway, unsteadiness of the gait. They also complain of giddiness, vertigo, and there are memory changes. The medical literature also says that psychiatric manifestations of depression because of low B12 level. Now, all these are become in a greater amount when it is subacute combined degeneration. Okay. But when it is low B12, it still has some manifestations like this. So fatigue, shortness of breath, anorexia, glossitis, angular chelosis, homocystinuria, neurological manifestations like tingling, numbness, unsteadiness of the gait, can't maintain the balance, giddiness, vertigo, memory changes. There are so many causes, they are overlapping. As your age is advancing, you have some memory lapses. Somebody has given a good example that you should say your computer memory is full. After some time, you remember the name of the drug or a person or the event. But till then, the memory is full. So there are memory changes and psychiatric manifestations like depression. Investigations commonly we do any patient coming with shortness of breath or with CBC. CBC will show you increased mean corpuscular volume because the B12, low B12 will cause large RBC. They're called as macrocytes. Because they are macrocytes, they are bigger in shape and size, NCV will be increased. There will be macrocytosis on peripheral smear. And the peripheral smear will show occasional megaloblast. Today we are lucky, we can directly measure the serum B12 levels. 25 years back when this was not available, we used to do an indirect test for intrinsic factor that was called as a Schilling test. But today we don't need it. We can directly measure intrinsic factor, but that also is not necessary for our routine practice. Routine practice, we can do serum B12 level. You should see the normal range of that particular laboratory. Most of them have 187 to 779 picograms per ml. Now this is picogram. Now, if the upper limit is 779, at least the golden mean of this should be around 450 to 500. So, if the B12 is towards 187 or less than 400, we can also call it as hypostate. Okay, there is no deficiency, but I have seen quite a large number of patients whose B12 is less than 140 and still they have these vague symptoms. They don't come with megaloblastic anemia or subacute combined degeneration. That means they are still using their liver stores. But in a healthy individual, if it is 779 picogram, it's well and good. If not, at least it should be around 450 to 500. If it is less than that, please replenish. And the third thing that you will test, suppose if you find or you suspect a low B12 in these people, MCV is increased, macrocytosis, occasional megaloblast, serum B12 is less than 300, towards the lower side, 187, 200, 202. Can you believe? I'm a fish eater, but I eat fish once in 15 days or something. 3 years back, just for the sake of it, I got my B12 levels done. They were 220. That means I am more like a vegan. I had to replenish it. Okay. So if it is serum B12 on the lower side, it is not a deficiency, but this is a low level and should be corrected. And then we do anti-parietal cell antibody test. If the anti-parietal antibody test is positive, I'll tell you the significance. That means the intrinsic factor is not secreted in the stomach, and therefore, if the patient takes any amount of non-vegetarian diet or any amount of B12 by mouth, it will not be absorbed. Therefore, this patient will require injectable B12. Injection B12 is now available. You give 1000 to 1500 micrograms per ml. Give it intramuscularly on alternate day for 4 to 5 injections. That will replenish the B12 levels. Then if parietal cell antibody comes positive, I cannot give them oral B12. If parietal cell antibody is negative, then what I do, I replenish by giving injections. Being water soluble, it is intramuscular, it is not given, it is not at all painful, just 1 ml that you inject for 4 or 5 injections. And then after 2 months, the patient should keep on taking, oral B12 or oral B complex for 10 days of every month. Now, if you see the B complex, the capsules or whatever B complex that you are using, the B12 levels will be hardly 5 to 15 micrograms. That is okay for our daily requirement is 1 microgram. But this 5 to 15 micrograms, that is in a free form. So that also can be absorbed if the intrinsic factor is present. So if parietal cell antibody is negative, we can give oral B12 after correcting the B12 levels. But then he should keep on taking every second or third month for about 8 to 10 days. However, if the parietal cell antibody is positive, then you have to give, or the patient has to take injection B12 once a month lifelong. Because oral B12 in these people will not get absorbed. The folic acid deficiency also has similar picture. And many people, instead of B12, give oral folates. Folic acid is commonly given. But let me caution you that if there is a B12, low B12, and if you give only folic acid, it aggravates the deficiency of B12. The person who was having very subtle symptoms by giving folates now comes with peripheral neuropathy. So neurological complications caused by B12 deficiency will be unmasked by giving folates alone. Therefore, what I would advise that give B12 first and then give folic acid. Then you can give combination of B12, all B complex enzymes and folic acid. But first make sure that what is his serum B12 level, parietal cell antibody, and then give injections and then decide about the oral treatment. If your patients feel that it is little costly investigation, then you can give injection B12 at least once a week for first 4 weeks and then keep on giving maybe once a month, depending on the cause. Because it is a water-soluble vitamin, whatever is excess will be stored in the liver, otherwise it will be excreted in the urine. So it doesn't have very serious side effects. Okay. That is only when the patient cannot afford these investigations. They're not very costly. Still, I do these investigations to show the evidence to the patient that you have low B12. Therefore, you have to take injection. And I send them to their family physicians and ask them that take 4 or 5 injections. If parietal cell antibody is positive, continue injection once a month. Okay, that is the advantage, that you have the evidence to show to them. And if you are giving orally, please, it takes a longer time. So please treat B12 first and then give folic acid. Nowadays, some B12 nasal sprays have come, but I'm sorry, I have no experience of using them. If you have the experience, go ahead with it. Now in pregnancy, we have studied folic acid deficiency in a great extent, but now we are also studying B12. And it has been shown that the B12 and folate deficiency, they affect the gonadal function, which results into infertility in both men and women. So if you have patients who come with infertility to you, or if you are doing pre-conception counseling, please include these in your counseling and get their B12 and full levels done and correct the deficiency if there is a B12 and folate deficiency. If the mother is deficient in B12, there are incidences of prematurity. There will be recurrent fetal loss. There will be neural tube defect. And the chances of hair lip and cleft palate are very high. That is the reason in antenatal care, we start giving folic acid from the very beginning to prevent the neural tube defect. Okay. So similarly, for all pregnant women, particularly those who are vegetarians or particularly those who are poor in nutrition, please give them supplements of B12 and folic acid in order to have a good pregnancy outcome and prevent all these congenital defects. Now coming to megaloblastic anemia, it is not very common. You may not see in your practice, because once in a while, if you see it, these are the conditions. It is autoimmune in origin. Antiparietal cell antibodies are present. Clinical manifestations will be all those manifestations of anemia. Peripheral smear will show raised MCV, macrocytes, and megaloblasts. Bone marrow will be megaloblastic, and parietal cell antibodies are positive. Like anemia, all signs and symptoms of anemia with hepatosplenomegaly will be present, and we have to treat this with injection B12. Subacute combined degeneration. Now, it is a degenerative disease. And what is the cause of degeneration? Deficiency of B12. So if we don't correct the deficiency, all the degenerative disorders are progressive. Secondly, it is affecting neurological system. So when it is affecting the nervous system, there are hardly few parts of the nervous system which can regenerate, like peripheral nerves, but others don't regenerate. Okay, and therefore this is a serious condition. We have to, if we diagnose it early and give B12, at least the progression of the disease will be stopped. So what is this subacute combined degeneration? Degeneration of various systems in the neurology. Peripheral nerves. So the patient comes with tingling and numbness of hands and feet. It's very gradually progressive. So initially he is not bothered. But as it goes on increasing from the feet, from the foot it starts and comes above the ankle, then up to the knee, and then above the knees. He may start simultaneously tingling and numbness of the hands. Because of this tingling and numbness, his gait is affected. He can't maintain his balance. He can't stand with feet together, what we call it as Romberg sign, and ask him to stand with feet together, close his eyes, and he starts swaying because his posterior columns are affected. Because the posterior columns are affected, his position sense is lost, his vibration sense is lost, and therefore you get these gait problems. The person says, I'm not alcoholic, but people feel that I have drunk and come. Because this particular, as I told you, when the person stands on 2 feet together with eyes closed, he can't maintain his balance. He starts, swaying on either side. But if his eyes are open, there is a visual correction and therefore he can maintain the balance. Then he tries to separate out his legs. So this difficulty is aggravated in the dim light. So when the person is coming from office or from his work in the evening, he walks like a drunkard. Why? Because his posterior columns are affected. He can't maintain his position and balance. Then the corticospinal tracts are affected, and therefore he will gradually develop weakness of voluntary activity, particularly in the lower limbs. He can also suffer from optic atrophy, and finally, the cells in the brain, they also undergo degeneration. Therefore, he develops dementia. Okay. So once he reaches to all these stages, it's not possible to bring him back. If he has peripheral nerves, little posterior column signs, it is at that stage we have to catch him, do serum B12 levels, start injecting B12, and the person will be near normal. All these complications or progressive degeneration can be prevented. So these are the things I wanted to tell you. And therefore, what I would suggest, previously when we were students, our teachers used to make fun of family physicians. And they used to say that family physician, for any patient who comes, will give first 2 ml of B complex. And therefore, Bombay municipal gutters are full of B12. Because all these B complex is excreted in the urine. So the Bombay municipal gutters are full of B12. Over the years, now as we have started measuring B12, and we have seen increasing incidence of autoimmune disorders and many drugs which are used, these drugs are antagonizing these B12. We are seeing large number of people. And again, I'm repeating, Harrison says 50% of Hindus are having low B12. So I don't think the family physicians are wrong in giving injection, but instead of B complex injection, which will hardly contain 15 micrograms of B12, give pure B12 injection. So injection B12, or you can give injection B1, B6, B12 regularly, and then give oral tablets. But we give this before giving them the folic acid. Now I'm going to talk about vitamin D. Vitamin D is a fat-soluble vitamin. The daily requirement of vitamin D is 400 international units. What is the source of vitamin D? The base source is our skin. It is synthesized beneath the skin by ultraviolet rays. We have our skin intact. Now we have to worry about the ultraviolet rays. Okay. And what is the dietary source? It is again animal source, and that is cod liver oil and fish oil. What are the deterrents for this ultraviolet rays? Dark skin. Having more melanin, the dark skin resists the vitamin D synthesis. There is lack of exposure to sunlight. Now, we used to be under this impression that we are living in a tropical country. We are not in England. We have plenty of sunlight, and therefore we cannot be deficient in vitamin D. But since the estimation of vitamin D has become available, I'm seeing large number of people are deficient in vitamin D. Large number. Not insufficiency, but deficiency. And large number of Muslim women are vitamin D insufficient because they are covering themselves with that black burqa. So sunlight doesn't penetrate. At this, I'll just tell you an anecdote. I usually do vitamin D for all these ladies who come with aches and pains and joint bone pains, and with their that burqa, vitamin D levels are low. Because the vitamin D level was low, I just passed a comment on that lady that why do you people wear this burqa? Because of this, your vitamin D is low and therefore your bones become very delicate and brittle. She took the prescription from me and she went down and complained against me to the hospital authority that doctor is criticizing our religion. I had never uttered a word about the religion. I just explained to her, because of your burqa, you don't get exposed, and see your vitamin D is only 6. So just be careful with this community. But that is one of the reasons that these ladies are deficient in vitamin D, and therefore they have a large number of them have osteomalacia. Now we all are exposed to the sun. But is our skin manufacturing vitamin D? The deterrent is getting the sunlight ultraviolet B rays exposure. And these ultraviolet B rays do not reach to us because of the pollution. There's such a thick cover of air pollution in Mumbai and other cities that these rays do not reach us. So we all are having, most of us are having low vitamin D. Now vitamin D, though we call it as a vitamin, it is a prohormone, that it is converted from D2 to D3. It is necessary for calcium absorption from the intestine. It is essential for calcium deposition in the bone matrix, and therefore it is very essential. If the serum calcium becomes low, to compensate for it, the parathormone is secreted. So parathormone levels go high. And parathormone, because the calcium is very, very essential for our neural function, neurological function. So parathormone, in order to increase the serum calcium level, will mobilize the calcium from the bones. So vitamin D deficiency, the parathormone will be high, which will mobilize the calcium from the bones, and the bones will become osteomalacic. Okay, and therefore it is very important that we maintain our vitamin D level. Recent investigations or research in this has shown that vitamin D has an immunological function. It has a role in infection. It was, I think, about 30 years back when I used to give a lot of lectures on tuberculosis. That was the time I used to show a slide. Now I didn't put it here. But vitamin D is directly activating the macrophages and limiting the spread of mycobacteria. You remember previously there was a sanatoria treatment for tuberculosis. What was sanatoria? The people were isolated so that they do not spread the disease in the community. And in sanatoria, they'll get fresh air and fresh sunlight exposure, and therefore this sanatoria treatment started in England. So the only reason was that vitamin D played a very crucial role in limiting tuberculosis. Now they are also saying that it is also playing a role in other infections. Then it plays a role in autoimmune disorders, And now it has also been shown that it plays a role in metabolic disorders like diabetes. Vitamin D deficiency has become a growing pandemic in India. It is called as pandemic, remember the word. D is linked to obesity and insulin resistance. 3 out of 4 diabetic patients in India are vitamin D deficient. 3 out of 4 diabetic patients in India are vitamin D deficient. It is essential for secretion of insulin from beta cells. Therefore, now they are saying, if you give D supplement to your people who are even younger generation, who are not getting it from the diet, please give the supplement to delay the onset of type 2 diabetes. It has also been shown that it has a beneficial effect in bringing down your HbA1c, controlling your fasting blood sugar, and it has also a role in type 1 diabetes. So we are not wrong if we give vitamin D supplement to our patients, particularly diabetic patients. It also affects the endothelial, the deficiency causes endothelial dysfunction. There is oxidative stress. So endothelial dysfunction means it will cause vascular injury, and therefore it will lead to cardiovascular problem, including coronary artery disease, hypertension. It causes myocardial fibrosis and cardiac hypertrophy. So in order to prevent all this, we, at least ourselves and to our patients, we can protect by giving vitamin D as a prophylaxis. How it is to be given, I'll come to that. It has been shown to have immune modulatory effect. Vitamin D acts on macrophages, T cells, dendritic cells, monocytes, and also B cells. So it affects both innate and adaptive immunity. Now, when vitamin D is deficient, we'll have, lot of infectious diseases. It makes us vulnerable to many of the infectious diseases. It doesn't cause infectious diseases because infections are caused by bacteria, parasites, viruses, fungi. But it makes us vulnerable to this. And in all these diseases, if we give vitamin D supplement, the recovery will be faster. It has also been shown to have a role in the autoimmune diseases. And nowadays, as I said, there is an increasing incidence of autoimmune diseases, maybe because we have become more aware, or maybe because the diagnostic tests are available, and therefore you see large number of rheumatoid arthritis, Hashimoto's thyroiditis, inflammatory bowel diseases, systemic lupus, and also type 1 diabetes. So all this can be helped, at least their severity will be reduced by giving vitamin D supplement. How do we give vitamin D therapy? It is oil soluble, and therefore we can never give it as IV injection. There is a separate preparation if you want to give it IV, but it is not necessary. I'm just diverting for a second. In small children, it causes rickets. In the adults, it will cause osteomalacia. And because of the osteomalacia, as you know, we'll have osteomalacic myopathy. We have brittle bones, so they can easily break. These are called as pathological fractures, can happen in the scapula, can happen rib fractures, or there can be even a collapse of the vertebra as a pathological fracture because of vitamin D deficiency. Okay, so it has to be given. I prefer oral therapy because it is easily available and it is absorbed from the GI tract. So oil soluble injection is intramuscular injection. Oral therapy is 60,000 units. If the patient is deficient, now you use your discretion. If you measure the serum serum vitamin D levels, and if there is insufficiency, then you have to treat the patient at least for 8 weeks. 60,000 units, one tablet is of 60,000 units. give once a week for 8 weeks. After that, if he is deficient in his diet and other things, then ask him to take vitamin D supplement at least once a month, which is to be continued. Along with vitamin D, you can give a supplement of calcium and also magnesium. So don't forget that. Nowadays, you are getting this combination, the calcium magnesium tablet along with vitamin D. Now, calcium magnesium tablet he has to take daily, but vitamin D once a week you have to give for 8 weeks. You can give it once a month for people who are above 45 years of age. All people. You are not wrong. Why once a month? Because being oil soluble or fat soluble, it can be stored in the body. And if there is a very high dose that if you continue every week for a lifelong, it will cause vitamin D toxicosis, hypervitaminosis. To avoid that, just give once a month as a prophylactic for all persons above the age of 45 years of age, both men and women, and also menopausal women. That is most important because their osteomalacia and also osteoporosis increases after menopause. So they are very prone to develop the fractures. So vitamin D therapy can be given in infections, in autoimmune diseases, and as a prophylaxis after the age of 45. Even your diabetic patients, you can ask them to take vitamin D. Again, T2 diabetes is more common after the 40 years of age. So they should take it 60,000 units of vitamin D once a month, and that they should continue. So I always tell them that choose the first Sunday of every month and continue so that you remember, first Sunday I have to take this. And that is how we can help our patient. There is nothing wrong if you are giving a prophylactic or supportive therapy with vitamin D. So that's all I wanted to share with you. Thank you very much. If you have any questions, please send to Dr. Preeti. She will communicate to me and I'll try to answer your questions. Thank you so much.